We'll jump into today's episode right after this announcement. For over 13 years, something remarkable has been happening. Rural hospitals and other small healthcare organizations that have partnered with Capstone have been achieving results and forming workplace cultures that even we are blown away by. It is truly a game changer when rural hospitals are the provider of choice and employer of choice so they can keep care local and margins strong. Far more healthcare organizations need to experience what's possible. That's why we're stepping forward in a bigger way, expanding our team of experts, expanding our capabilities by adding a strategic planning division to expand our ability to help even more rural hospitals and other healthcare organizations in 2026 and beyond. Capstone will continue to be the partner that small healthcare organizations can count on to meet them where they're at and guide them towards a stronger future. You can learn more at capstoneleadership.net.
Welcome to Culture Change RX, the podcast for healthcare professionals that are committed to creating a thriving workplace culture, improving the experiences of employees and patients, and ultimately unlocking their organization's next level of potential. I'm Sue Tetzlaff, your host and co-founder of Capstone Leadership Solutions. Join me and my insightful guests each week as we share actionable insights for navigating the crucial people side of the business of healthcare. Subscribe now for a weekly dose of Culture Change RX. Now let's dive into this week's conversation where culture change takes center stage.
Welcome to another episode of Culture Change RX. It is me, Sue Tetzlaff, co-founder of Capstone Leadership Solutions and the host of Culture Change RX. Today is one of those episodes where we have a guest in the studio, and we always start by having our guests introduce themselves before we jump into our conversation today. And today's topic is on innovation and AI in rural healthcare. And with me, I have Darrell, and we're going to start with that introduction. Welcome, Darrell.
Thank you so much, Sue. It's a pleasure to be here. My name is Darrell Bodnar. I am the Chief Information Officer for North Country Healthcare. North Country Healthcare is a small group of critical access hospitals, kind of unique in the fact that we came together without a tertiary hospital affiliation. And we are completely independent with a home health agency, and we serve the northern third of New Hampshire. Pleasure to be here, Sue.
Yeah, glad to have you here. And one of the things I wanted to mention to the group is that our company, Capstone Leadership Solutions, we got to know you through the work that we're doing on your One Team, One Mission initiative for the transformation aspect of your organization's culture and leadership, patient employee experience. So, and that you're leading that initiative. I just wanted to mention that as part, you're serving as the initiative champion. And some people might go, what? A CIO is leading that. And so I think that actually tees up what's so amazing about what we're going to talk about next, because even though AI is a technology and some people might think about a CIO not really leading culture, not really leading quality and safety in healthcare, you are a leader that is leading a major contributor to that in your organization and innovation in your organization. And I just want to, in the introduction and start here, give a nod to that of what I see in you as a leader. And the industry is seeing it too, because you've been recently speaking at Becker's and the American Hospital Association Rural Healthcare Conference. And so I love that from northern rural New Hampshire, you're getting an audience with big national conferences around your innovation and AI, and you're really becoming a leader in healthcare. And so this podcast is a platform for you to be able to share some of what you've been talking about at those conferences with our audience. And I appreciate you being here to do that. So let's start with, you have been speaking a lot about this to inspire other healthcare organizations to do what you've been doing, start what you've been starting here in AI innovation. So where do you want to start in sharing what you've been up to?
I appreciate it. And thank you for that wonderful introduction. But I don't know if it's unique or not, but I think we have a very a unique situation in North Country Healthcare because, We are big enough to make an impact, but small enough to be very, very agile. And I think that's been a key success factor for some of the initiatives we've done. And I want to know that, like most systems, artificial intelligence, innovation, those are not a technology component that's related strictly to IT. If you're going to move an organization, it takes teamwork, it takes collaboration. And some of the journey that we've been on with Capstone and our One Team, One Mission has led to that. So I don't want that to go unsaid, because it's a key factor in making sure you can have that level of connectivity within your organization. Some of the things we spoke about, I was probably a component of it, but it was led a lot by our Chief Quality Officer, Bernie Adams, and our Chief Nursing Officer, Tiffany Haynes. And it came with the fact that we were looking at doing things like barcode administration, a big challenge when it comes to patient safety and the outcomes that it have. And that was one of the topics that we spoke on at the American Hospital Association's Rural Health Conference. Within that, what we were able to do is by leveraging our internal EMR to create alerts and channel those alerts in an appropriate manner to the appropriate individuals within the organization to act upon, and then put measurements around that through our quality team to make sure we weren't going to miss anything. And when I say we've deployed this, we've deployed it to all service lines. So, historically, the ED may have had a level of forgiveness because of the level of busyness that they have in that, and the nature of the patients and the care delivery. But we didn't. We included all care delivery areas. The leapfrog standard is 95%, but our CQO and the leadership was not happy about that, because that left, in our particular care setting, 3,000 to 5,000 potential misses annually. That's a lot. Would you want me to tell you that, 5% of the time we might miss giving the appropriate med to your family member? That was unacceptable to us. So we put in a lot of tools and mechanisms, and this is the innovation. It's not a single solution. It's a collaboration. Our scores have been well over 99 for over a year, I think maybe even 18 months now. Historically, and most of the time, we hit 99.5%. And this is across all care settings. And it's truly phenomenal because it's focusing an organization on a very specific goal. And when you get to that goal, it also makes that sustainable. So when you decide to move to another goal, this doesn't drop because the workflows and the mechanisms are all in place. It is one of the ones that I think I'm most proud of. And to your point earlier, I'm the CIO. This is not typically a place where you get this involved, this in depth, but it's patient care. And that's what we're all here to do.
You're speaking of high reliability, and I know that your organization strategically has its sights on high reliability. And recently, we've been doing a lot of additional speaking on that topic too, of high reliability. And one is not none, right? So you can't have that. 5% is a lot, right? And we got to tease that out. And what you're speaking to is proof that it's possible. That's one of the messages I love getting out there, because you guys are showing evidence and proof that things that we thought were impossible, teasing out this last bit of variation that does have negative impact on individuals, that it can be teased out of the system and the processes so that we can get better and better, high reliable results and sustain them. That it's not a blip we have the systems that repeat over and over again to get the result consistently over and over again. So I love that evidence that you're showing for high reliability.
I love our journey of high reliability. We have actually just kicked off a major initiative where we are requiring all staff to go through the high reliability education. And oddly enough, once again, I love the people I work with. We searched high and low for a framework, a tool set to be able to deploy and educate and really bring forward our path to high reliability. And, it really is not out there, and it's not really designed. So our teams came up, and believe it or not, part of our One Team, One Mission journey, those teams helped develop this, that HRO team. And they've put together an inspiring education for our staff. I sat through the first one this week. It could bring tears to your eyes to hear the stories of why we're doing this. Our CEO, Tom Mee, shared, he's a nurse, and he shared a traumatic experience he had early on in his career where it resulted in the death of a child. And you want to hear an inspiration to move an organization. That will do it. Mm-hmm. And then once that happens, that's it. Your path, your goals have been set, and that's the path you're going to be on. It's an amazing journey to watch it unfold. And we're doing it at every level. You mentioned HRO, and deference to expertise is the key to this in many, many aspects of it. allowing the people who know the care delivery to be able to respond, to have input, and to help develop those programs. We've duplicated this in different areas. We went, I believe it was 13 or 14 months without a hospital-acquired infection, using the same tool set that we used for our barcode scanning. That's an incredible testament to all of the people involved. And the people who developed the process were the nurses on the floor. They knew where the challenges were. They needed to do this. We then manipulated our EMR to get to that point, and then put in measurements, and we went through, and it was great. And I'm telling you, when we had our first hospital-acquired infection, it resonated throughout the hospital. Everybody sort of knew that we had this. Now, it's going to happen. I mean, we're a healthcare system. But the fact that everybody was alerted to this came up at our CEO cabinet group to say, hey, we finally had this. It's a real testament to how focused we are on the care delivery for our patients.
That sensitivity to failure is also part of high reliability. And it reminds me, this can be applied to the service area as well as quality and safety. It reminds me of my husband, who's a physician, when he was working in an organization where there was a lot of complaints about the care, about the service, the patient experience. And every day when he would make rounds, he would hear these complaints from patients, from families. And that was just part of his experience as a provider in this organization. And it was so much so that he couldn't do anything with it. He couldn't follow through on each and every one and resolve them, or he would never have time to do his job, and get through rounds. And so he would just keep going, right? He would just, yep, I heard that. Yep. But let's focus on your care plan for today. Let's focus on, whatever. He did his part. But once the organization transformed into top ranking, award-winning patient satisfaction, once that happened as a provider, if he heard a single complaint on rounds, he immediately had to do something about it and get people involved and service recovery and figure out why it even happened, because, they were at a different place. And it sounds like you've gotten maybe not in everything, but we have to get our organizations to these different places where one bad outcome, one error, one misstep, one complaint, it alerts us to a system failure, right? Where if it's so many, it almost feels like we just don't have the bandwidth to do that.
No, and you're absolutely right, Sue. And when you become so confident in the fact that you've built the system and you do have a failure, it really alerts you and it narrows that margin even more. And I can promise you that those clinical teams who had that infection were certainly correcting that. And we'll see if we go the next time, we'll go 2 years without one. You never know. I think you're right. And it's another pillar, a preoccupation with failure. For those of you on the podcast, I'm sure preoccupation with failure, reluctance to simplify. Mm-hmm. Sue, you mentioned sensitivity to operations, knowing how those work and working as a team. Deference to expertise, and then finally the commitment to resilience make that difference. That resilience part is something that has been embedded within IT. I've talked many times about the use of AI and technology and what we've done, and probably one of the biggest threats, I think, to the continuous delivery of healthcare is the cybersecurity threats that we're experiencing. We've deployed a lot of technology and a lot of AI in this space because if providers cannot access the systems, all of those things, those systems are the foundation of this. Mm-hmm. We have to. So making sure, my job is to try to ensure that those systems are as available as they can possibly be. Not an easy task in today's day and age. And we're watching now that we've had attacks, and there was an FBI bulletin that went out on Thursday that discussed the challenges with AI-driven attacks. These are actually systems where you can rent a phishing as a service and AI will do the work for you. It's a new world, and you need to have the technology in place to be able to help combat that.
Mm-hmm. How are your staff and providers taking to this? It does mean a change for them, right? And even you talk about medication administration and errors, and when those alerts come up or when those errors are detected, they can have confidence in that, but also, the culture has to be safe around that too, that it's not punitive. And on the front end, they can be part of advising, helping, being part of creating all of this, but on the back end, working every single day with it in their work. So how are the providers and the staff feeling about this type of innovation in the workplace?
A multi-pointed answer, but just culture, which is a key component of high reliability, to be able to make sure that we ensure that people can speak up, people can talk without the fear of retaliation or anything, to be able to drive this forward. And we've actually built in a just culture algorithm into our incident management system, which is great because it allows us to be able to really judge how people are doing things. And when it's not malicious with intent, it always makes a big difference, of course, and people are trying to do the best they can. I think initially the technology and the innovation challenges were received a little bit. They were warmed. I won't say they were really welcoming, because we're changing their workflows. We're focusing this, and we're shining a light directly on the things that are bad. We always talk about, showing us your warts. Well, this is where they are, and let's try to work through this. I think we've turned that. We've seen the difference, and I think people are bringing forward suggestions. This is a problem. This is what we should be looking at. And part of our overall development, and a lot of this comes back to our One Team, One Mission journey with Capstone, is developing goals, system level goals that drive this, and ensuring that those goals are created accordingly and appropriately so that they can cascade down to the front lines. Now, the genesis of the goal probably originated somewhere in a clinical area, clinically driven all the time. But then we develop a goal and watch that goal cascade down. It's been very, very good because it's a driving force. And in some cases, we've attached performance to this. You're meeting performance if you can achieve it. If you're not, you're falling before. And if you really excel, then you're exceeding that performance level. I think that's when you really get to drive people towards this. The providers, honestly, they've had such a rough time of it over the past few years, coming off of post-COVID and then trying to deal with this overwhelming amount. And honestly, the volume of information that they have to deal with on a regular basis is sad. So when we've introduced things like ambient AI into their workflows, it's made a huge difference from them, because now they can take a portion of it, their note creation, to be able to focus on the patient. We're now working towards, looking at prior auths, doing orders and things to make their lives much, much easier so that they can focus on what they got into medicine to do, which is to treat patients. We've deployed some technology on the back end now as we're looking at revenue cycle to take away some of that coding problems, because unfortunately we made our providers, documentation specialists, transcriptionists, and coders all within the same mix. And to me, it's been a lifelong journey. The introduction of EMRs and watching those deploy, the shift of the workload onto the clinical staff. Now I'm starting to see it move away again to where we're moving it and allowing technology to pick it up. That's a huge thing. And I think it's the key to the success of healthcare going forward, because the volume of information they're dealing with. And to keep going on in this, we're deploying technology now that uses some of the generative AI. It's fantastic at summarization. And when you get a 50-page referral coming in that you're going to have to treat a patient, how can a provider possibly digest that in a manner that's going to go through? And once you build, and we always use a trust but verify model, once you build a technology that can take that information and give them a summary of the key components of that, and they trust it and they verify it, it gets you to a point where their workload, now we're making them the best they can possibly be. The talk of AI replacing providers is not going to happen. It's not going to create clinicians, but we can certainly make them the best they possibly can be. And I think that's what we're starting to see now in some of the outcomes and the changes that we're having.
Yeah. That frustration reduction for sure. I watched my husband in practice with that, how much paperwork there was to get approval and authorization to really advocate for his patients, to even get durable medical equipment like assistive devices. And I mean, how much paperwork and advocacy he had to do just to do a simple thing like that, or get a test or a treatment authorized. I mean, just pre-auth alone is a lot. And then, of course, the documentation, frustration and reduction. I mean, it's just so big. Yeah, I remember when electronic health records first came out. We've been in it long enough to see that transition. And I remember, as the wife of a clinician, a physician, is now we have a computer in our bedroom, because what does he have to do in the middle of the night? He has to get up and he has to access information and he has to put in information. And certainly if we can reduce that burden and frustration, for sure. One of the things that you mentioned that I just want to pull out, when you mentioned goals, a couple things there. is that obviously you already are talking about data, like we're above 99%. Da, 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 da. So, you can speak the data of change. We were at this, now we're at this consistently. And I do see that organizations that are on this trajectory and have their sights on high reliability, data means a lot. And the goal cycle and the cadence of activities to set and cascade goals starts to take on new meaning. And actually, one of the meanings that it takes on, which kind of gets to my other point, is a thirst for winning, to feel like winners and to be proud as winners in this game of healthcare. And I don't mean to like minimize that it's all fun and games, but the culture of excellence is really like the culture of being on a winning team and being proud for your individual contributions to it. But more importantly, maybe being part of a team that is working together. It's not just one person getting the results. It's something that we all have a part in. And that pride, I watch this in the faces and the voices and the statements that I hear from employees that are involved in these kind of innovations and creation of these amazing results. Is it moves them to tears with such pride that they were part of it. They were embraced and engaged to be part of it. And it wasn't just the work of leaders. It wasn't just the work of a few people. It really was an all-in team effort by everyone. And that just speaks to your one team, one mission. If nothing else, it just sums it up right there. So I don't know if you want to speak at all about this culture of winning and improvement and the engagement of everyone in that as a team, and also the use of data and how it's becoming maybe different than it was before as you're on this journey.
I'll speak to the data first. Is that having data is key to this, and having measurable data and making sure you're looking at the right data. We have brought in some individuals who are key to this, because I think sometimes you can use data to tell whatever story you want to tell. So it really needs to have an unbiased effect, and it needs to be very, very focused. And you need to tease out those things. And you really, really want, it's very, very easy for people to dismiss anomalies within the data or to carve out those pieces. And I think when you're looking at trying to do that, it's not there. So you want somebody who's unbiased to be able to drive that. Once you have trusted data that's out there and you can use that as a mechanism to move forward, then it becomes more now. The journey to this is getting the staff together as a team to realize that's why we're here. That's what we do. I think that's a little bit easier than I would have expected. What we've noticed is that some people who were really not ready to be on that journey have found other paths in their career to go elsewhere, because this is the journey. This is what we're here to do. And I think when you look at just culture and you distill that down into what it could be, it's to do no harm to any patient and to provide them with the best quality care we can provide it. Way back when I was a student of the Disney Institute, and I truly believe that one of their premises was that Cinderella can never have a bad day. And when our patients come in, I don't care what face they put on, they're probably not having their best day. They're probably having their worst day. And we need to be there to be able to move them. That's a team effort. That is everybody along there. And I think one thing that healthcare could benefit from, and another Disney Institute quote was, they're all cast members. And as far as I'm concerned, the housekeeper, the physician, and everybody in between is a caregiver. We are there to care for those patients. And when you develop that sort of sense, and we're certainly not there yet, but we're getting closer to that model, that makes a difference, because the patient is always at the center. We are there for them to do this. And on their worst day, we need to have our best. Absolutely every time.
Mm-hmm. I love that you mentioned everyone being a caregiver. It reminds me of a statement that a pulmonologist, intensivist physician said one time to me. We were in a meeting where we're working on a quality improvement to get to zero defect in an area where we went years with zero harm in a certain area. I remember the early process of collaboration around that. And he would say, we may not be at the bedside of the patient right now, but here in this room, we are saving lives, right? So not only are we not all clinicians, but even if we're not at the bedside and we're doing this work behind the scenes, collaborating, working together, like you as the CIO with your quality people and your nursing people to whatever, like you're saving lives, Darrell. I don't know if
everybody is.
You are like, yes. And I think that when we come to healthcare, clinical or non-clinical, which I like to describe sometimes as the two biggest silos in healthcare organizations, is the clinical and the non-clinical. And we need each other so much to all be one team with one mission. Like, even when you mentioned about the financial pieces, right, of the documentation and the coding or whatever, is that those financial people, they support our mission, our business in so many ways. Like we can't do these things, offer these things, if that part of our business isn't reliable as well, right?
Oh, I completely agree. I've watched our CFO is amazing, and his team is amazing. And you've seen it, Sue. There's been so many rural healthcare organizations that have closed. We're seeing hospitals that are right now in danger of closing across the U.S. And this is key. And if we aren't financially stable, we can't move forward with this. And once again, technology comes in. We've had a couple of challenges with some revenue cycle work we've done, but the efforts that is starting to pay off is amazing. And we've partnered with some great organizations. So we all know that payers love to pay the full bill. That's being a little bit, and they tend to push back, and they're using AI and other technologies to try to get those prior auths dismissed. We've now partnered with an organization that is using their own AI to battle their AI. So now that's the battlefront when it comes to prior authorizations and reimbursement, and that's all due to the work of our financial team and our revenue cycle teams. You're right. Behind the scenes, nobody sees it. Who wants to talk about billing? It's more complex. You think in the world of IT, how complex it is? I would not want to be in healthcare billing because that is the most complex thing I have ever seen in my life. But they manage it and they do that. And they're the unsung heroes behind a lot of this because that gives us the financial stability, the financial resources to make these differences for our patient. It's a very good call out on your part. They're key.
Mm-hmm. Yeah. As we get ready to wrap up, because I told you 30 minutes goes by really fast. And so I know there may be some advice, a story, any sort of wisdom or inspiration that we didn't want to miss out on relaying today.
As I think about it, I think that the path is already there. First of all, I do think to make sure that your patients realize that you put your best face on when they come in. They are having their worst day and make sure it's the best. And I would sit and walk through your own department, evaluate it with a fine-tooth comb, and really explore it. And look at the 5 pillars of high reliability and how you can apply those to the specific department. How can I make this better? I believe in that framework. And when everybody is playing by that, I don't think we can fail. I think we will succeed. We will have mishaps, but I don't think we can fail. So I would take those pillars and apply those to your own department, your own organization, whatever you can possibly do to achieve that. I think that is the key to this. And you're right, 30 minutes went by fast. I think I could talk to you for 2 hours without a break.
I know. Your final comment there about, individual leaders and their ability to see their department through the lens of these 5 HRO components, what that made me think about is just that importance of the role of leadership, but in particular, that local level leadership closest to the patient, closest to the process, closest to the people, how important that level of leadership is to the things we're talking about here, like the big strategic priorities for high reliability and how we get there through things like AI and innovation and other things like that. But it really does take leadership. And, I know this from my own experience as a healthcare leader for 22 years and being a senior leader, a leader of leaders per se, is that is such a hard role. It is such a hard role. And for that middle management level, they've got to react to day-to-day operations, equipment that breaks down or a supply that runs out or somebody doesn't show up for work, all of that stuff is happening and it's going to impact care, right? So they got to be there and have systems and processes to make sure that kind of stuff, we call that the whirlwind, gets taken care of. And that's going to take some energy. Then there's the management stuff and the tasks of payroll and ordering and budgeting and all that. So they got that on their plate too, Darrell. But then what you're really talking about is leadership, making things better for the future. And so many leaders have very little time or sense they have very little time, energy, or maybe even the know-how to be able to know how to do that, engage their staff in doing that, and carry that through to optimal results that are measurable. Like that's a whole different level of healthcare leadership at that middle management level. And I just want to give props for your organization at the investment you're making in your leaders to be able to do that important work of leadership, not supervision, not management, true leadership, make things better for the future. That takes an investment and a commitment by an organization. So we can't just expect them to do it and not help them, support them, teach them how to do it. And I just want to give a shout out to your organization for the level of commitment you have to that, because that's all wrapped in this.
No, and I appreciate that. It is. And it comes from, in this case, the top down, but the process is the bottom up. And those are the key components in this. And you're right. Middle managers are the key to success across the organization, no matter what you do. And you have to provide them the guidance. You have to empower them. You have to give them that ability to make choices and give them the knowledge to do. And to your point, give them the time. I can't think of anything more important than those 5 pillars that we do, whether it's a budget cycle or whether it's a scheduling problem that you're having. That needs to be the primary focus, and the rest of it is secondary when it comes through, because those are the operations that will keep going forward. And that's where you have impact to your patients. I completely agree. And it has to be endorsed. I think NCH did a fantastic thing years ago when we insisted that every single individual was yellow belt trained. For us, it's a condition of employment. Mm-hmm. It's a condition of employment to go through HRO training. You have to go through this. Mm-hmm. And once we start to tie goals to this, it's going to be a condition of your ongoing performance improvement.
Mm-hmm. Doing so many things right there. And again, offering up proof that high reliability is possible through the results you're getting from these efforts, and very inspirational for others. When people think that it's not possible, I just love being able to share stories and put out stories like your organizations to show what is possible, so that we can continue our efforts all across the industry to get on the pathway to high reliability. So thank you, Darrell, for being here. I do appreciate your time and your inspiration that is getting out through the example of your organization and its efforts.
Thank you so much. It was a pleasure to be here. And thank you to your organization for helping us on this journey.
Our pleasure and honor. Yes. Thanks, Darrell.
Thanks for tuning in to Culture Change RX. If you found value in today's episode and you are a believer in fostering change in healthcare, join us in making a difference. Follow, rate, and review our podcast on your favorite platform. Share it with colleagues and your network. Together, we can make a lasting impact. Until next week, keep inspiring positive change.